Introduction. It is the most common form of cyanotic heart disease. It occurs in approximately 1 in 3,000 live births and accounts for 10% of CHD. It is also the most common CHD requiring surgical correction in the first year of life, without which only 10% of patients survive beyond the age of 20 years. French physician Louis Arthur Fallot, who first described Tetralogy of Fallot in the late 19th century, defined Tetralogy of Fallot. Tetralogy of Fallot, which is one of the most common congenital heart disorders, comprises 4 anatomic malformations, 1 right ventricular hypertrophy, 2 pulmonary valve stenosis, 3 transposition of the aorta, 4 ventricular septal defect. Causes of Tetralogy of Fallot. The causes of most congenital heart diseases, CHDs, are unknown, although genetic studies suggest a multifactorial etiology. Prenatal factors associated with a higher incidence of Tetralogy of Fallot include 1. Maternal rubella, or other viral illnesses, during pregnancy. 2. Poor prenatal nutrition. 3. Maternal alcohol use. 4. Maternal age older than 40 years. 5. Maternal phenylketonuria, PKU, birth defects, and diabetes. 6. Children with Down syndrome also have a higher incidence of Tetralogy of Fallot, as do infants with fetal Hydantoin syndrome or fetal carbamazepine syndrome. Pathophysiology. The initial defect in Tetralogy of Fallot is a narrowing of the right ventricular outflow tract into the pulmonary artery. This prevents deoxygenated blood from entering the pulmonary circuit. In response to this outflow obstruction, the myocardium of the right ventricle hypertrophies in order to contract forcefully enough to push blood past the stenosis. Additionally, patients have a large ventricular septal defect which allows shunting of blood between the ventricles. Blood from the right ventricle is then forced into the left ventricle, creating a right-to-left shunt and subsequent cyanosis. Finally, the aorta overrides the ventricular septal defect, straddling the VSD. This allows deoxygenated blood shunted from the right ventricle to immediately exit the heart mixed with blood from the left ventricle. The most important determinant of the severity and clinical consequences of TOF is the degree of right ventricular outflow obstruction. Infants with mild degrees of RV outflow obstruction may initially even have symptoms of heart failure caused by a ventricular level left-right shunt. In these patients, cyanosis is not present at birth, but with increasing hypertrophy of the RV infundibulum as the patient grows, cyanosis occurs later in the first few months of life.
In contrast, in infants with severe degrees of right ventricular outflow obstruction, neonatal cyanosis is noted immediately. In older children with unrepaired tetralogy, dyspnea occurs on exertion. They may play actively for a short time and then sit or lie down. Characteristically, children assume a squatting position for the relief of dyspnea caused by physical effort. The child is usually able to resume physical activity after a few minutes of squatting. Hypercyanotic spells, formerly known as TET spells, life-threatening hypoxic event with a dramatic decrease in oxygen saturations. Mechanism is usually infundibular spasm, which further obstructs pulmonary blood flow and increases right-to-left flow across the ventricular septal defects.
Typical hypoxic spells occur in the morning soon after awakening, during or after a crying episode, during or after a feeding, during painful procedures such as blood draws. Typical scenario includes tachypnea, irritability, and increasing cyanosis, followed by flaccidity and lost consciousness.
Home treatment for the caregiver. Soothe the infant and place him or her in a knee chest position, Notify the healthcare provider immediately. Chest X-ray. Patients with TOF have right ventricular hypertrophy, a boot-shaped heart and decreased pulmonary vascular markings. Electrocardiogram. On EKG, patients with Tetralogy of Fallot will show increased right ventricular forces as evidenced by tall R waves in V1. Additionally, right atrial enlargement is manifested by prominent P waves in V1. Right ventricular hypertrophy is demonstrated by a rightward deviated axis. Echocardiogram. Findings on echocardiogram are the mainstay of diagnosis in Tetralogy of Fallot. Echocardiogram will demonstrate a ventricular septal defect with an overriding of the aorta, pulmonic stenosis and right ventricular hypertrophy. Hypoxic spells should be recognized and treated promptly. It is important to educate parents to recognize the spells and know what to do. Oral propranolol therapy, 0.5 to 1.5 mg per kg every 6 hours, is occasionally used to prevent hypoxic spells while waiting for an optimal time for corrective. Neonates with marked right ventricular outflow tract obstruction may deteriorate rapidly because, as the ductus arteriosus begins to close, pulmonary blood flow is further compromised. The intravenous administration of prostaglandin E1, 0.01 to 0.20 micrograms per kg per minute, a potent and specific relaxant of ductal smooth muscle, causes dilation of the ductus arteriosus and usually provides adequate pulmonary blood flow until a surgical procedure can be performed. Prevention or prompt treatment of dehydration is important to avoid hemoconcentration and possible thrombotic episodes. Surgical management. Infants with symptoms and severe cyanosis in the first mo of life usually have marked obstruction of the rot. Two options are available in these infants. The first option is corrective open heart surgery. The second option is a palliative systemic to pulmonary artery shunt. Palliative shunt procedures. Shunt procedures are performed to increase pulmonary blood flow. Indication: 1. Neonates with TOF and pulmonary atresia. 2. Infants with hypoplastic pulmonary annulus. 3. Children with hypoplastic native pulmonary arteries.
4. Unfavorable coronary artery anatomy. 5. Infants younger than 3 to 4 months old who have medically unmanageable hypoxic spells. 6. Infants weighing less than 2.5 kilograms. Classic Blalock-Taussig shunt, anastomosed between the subclavian artery and the ipsilateral pulmonary artery, is usually performed for infants older than 3 months because the shunt is often thrombosed in young infants. Modified Blalock-Taussig shunt, a Gore-Tex interposition shunt is placed between the subclavian artery and the ipsilateral pulmonary artery. This is the most popular procedure for any age, especially for infants younger than 3 months of age. The Waterston shunt, anastomosed between the ascending aorta and the right pulmonary artery, is no longer performed because of a high incidence of surgical complications. The Potts operation, anastomosed between the descending aorta and the left pulmonary artery, is no longer performed either. It may result in heart failure or pulmonary hypertension, as in the Waterston operation. Complete repair surgery. Total repair of the defect is carried out under cardiopulmonary bypass, circulatory arrest, and hypothermia. The procedure includes patch closure of the VSD, widening of the RVOT by division or resection of the infundibular tissue, and pulmonary valvotomy. Complications. Bleeding problems may occur during the postoperative period, especially in older polysystemic patients. Pulmonary valve regurgitation may occur, but mild regurgitation is well tolerated. Right bundle branch block on the ECG caused by right ventriculotomy, which occurs in more than 90% of patients, is well tolerated. Complete heart block, that is, less than 1%, and ventricular arrhythmia are both rare. Nursing diagnosis for Tetralogy of Fallot: risk for decreased cardiac output related to structural abnormalities of the heart. Activity intolerance related to imbalance in the fulfillment of oxygen to the body's needs. Impaired growth and development related to inadequate oxygenation, tissue nutrisis needs, social isolation. Risk for infection related to the general conditions is inadequate.